The purpose of this video is to provide some of the key economic concepts and results for comparing health insurance around the world. As we have found throughout this course, a clear thinker needs to be on the alert for homonyms, words that have multiple meanings that are not even close to being synonyms. In an earlier lecture, we had fun with the homonym story of my young son who got confused between the free McDonald's sandwich, a Big Mac, and a free large-size Apple computer. Here we have a near homonym alert. Three very similar words with distinct meanings. Some people treat them as synonyms by accident. Perhaps others treat them as synonyms to fool you. Let's begin with health. Health is a result. It is part of well-being. It is the absence of injury or illness. Health care includes treatment by doctors, nurses, medicines. Health is different from health care in two important ways. First, health care is an input often intended to enhance health as an output. As a result, the people with the least health often get the most health care. Second, health care is not the only input or even the most important input. The patient herself is an important input into health. The patient can administer herself a healthy lifestyle and be attentive to symptoms at the early stages. Health insurance is not health care and is even further from health. Health insurance is one way to pay for health care. It is a way to pay the doctor or nurse. Health insurance can reduce health by reducing the financial incentive to stick with a healthy lifestyle. A diabetic without health insurance may strive to use less doctors, nurses, and hospitals by adhering closely to his regimen. Diabetes inheritance is by itself a major mover of health costs because over 30 million Americans have that disease. It is not uncommon for health insurance to be used to pay for medicines for recreational use that reduces health and even causes death. A big part of the opioid epidemic involves lots of health insurance and very little health on average. The point here is not that health insurance is always the opposite of health, just that they are not synonyms, not even close. Let me tell you a story about a day I testified in Congress. The ranking House member Maloney was trying to get each witness to either extol Obamacare or declare himself against health. She was going to coax this out of the witnesses by treating the homonyms as synonyms. So in her telling, Obamacare is equivalent to health insurance, which is equivalent to health care, which is equivalent to health. The first one is not even true because Obamacare is a 1,000-page law that has many things in it other than health insurance. For example, Obamacare also transformed the market for federal student loans. Congresswoman Maloney started with me. I am always on homonym alert, so she soon tired of trying to lead me there. The man next to me had a small business in Indiana that was damaged by Obamacare. He wanted the law repealed. For what it's worth, he's a nice man too, and helps run an orphanage in his spare time. But he is not a professor and not always on homonym alert. So in a few seconds, the Congresswoman had him tied up between Obamacare and health. She finished off with an oratory as to how Mr. Sergio wants to sentence tens of thousands of people to death. There are three major features of health insurance. The three are different. They are not mutually exclusive, but nonetheless, they are often treated as synonyms. The first feature is universal coverage. It means that all residents have health insurance. One way of achieving universal coverage as Switzerland does, is simply to require that everyone purchase private health insurance. The second feature is single payer. People get confused about it, but the two words are simple enough. Single means one. That is one payer for healthcare. Just one insurance company in the entire country. I guess in principle that one company could be private, but in practice, it is the government. Note that single payer does not happen by itself. Having the government be a massive insurer is not enough to have single payer. Still, some private companies will get in there to compete. Like in the schooling sector, where you have most of grade school and high school students at government schools, but nonetheless, private schools are there in the market. So single payer requires a prohibition of the second payer, a prohibition of the third payer, etc. A true single-payer government says to the private companies, it is illegal for you to offer the insurance product to anyone in this country. They are only allowed to shop with the government insurer. The third feature is free. Nothing in life is truly free, but here we mean at the time of service. What you get when you are sick has nothing to do with what you pay. You are not turned away for failing to pay an insurance premium or for failing to pay the deductible. All of your health care is paid for with other people's money. These three are not synonyms. You can have universal coverage without free and without single payer. You can have single payer without free or without universal coverage. You get the idea. Let's listen to Senator Bernie Sanders glide from the universal coverage feature, which excites his audience and is prevalent around the world, to single payer, which is different and much less prevalent.
Is doing what every other major country on earth does, guaranteeing health care to all as a right. I live 50 miles away from the Canadian border. This is not a communist society up there in Montreal. They guarantee health care to all. They spend 50% of what we spend. Is passing a Medicare for all single-payer system a radical idea?
Medicare for all is all three of these. A lot of people like the universal coverage, but that doesn't mean they have to like single payer or that they have to like free. There's another homonym alert here. Medicare for all is not Medicare. Medicare is the U.S. health insurance program for the elderly since the 1960s. Medicare has only the universal coverage part among the elderly. Medicare does not have free. It does not have single payer. Actually, Medicare is something like 1,000 payer, with lots of private insurance companies serving people on Medicare. As it must as a single payer program, Medicare for All abolishes Medicare as we know it. None of those private companies can be allowed. An aspect of universal coverage is the individual mandate. That says that people are required to buy health insurance. But in a number of countries, that requirement is just a matter of asking nicely. There's no penalty. Somebody in Australia or Japan or the Netherlands gets no penalty for failing to buy health insurance. The U.S. is mixed. In effect, the elderly in the U.S. get a penalty for failing to sign up for Medicare. But non-elderly can go without insurance with no penalty. Now let's talk about free. A copay is a payment made by the patient at the time of service. It is called a copayment because it may not be the only payment. An insurance company may also be paying part of the bill. Examples of patient payments are deductibles. They have to pay the whole amount until their spending for the year is high enough, after which time insurance helps pay. Copays can be a percentage. Maybe the patient pays half and insurance pays half. Co-payments can be a low dollar amount. Generic prescriptions are especially that way. The patient pays $3 when he picks up the prescription and the insurance pays the rest. People making co-pays are not getting free health care in any sense of the word. If you refuse to pay your $3, you are not getting your prescription. Free health care is quite rare around the world. With only a little exaggeration, you can say that the Nordic countries have single payer, or did until recently. But they do not have free health care. The Nordic people have co-pays. In percentage terms at least, Sweden's co-pays are about the same as co-pays are in the United States. Single payer likely results in less spending on health care, lower prices even. But as we will analyze in the monopsony section of this course, single payer does so by purchasing less health care. The single payer system squeezed the doctors and hospitals and drug companies by purchasing less visits to doctors, less visits to hospitals, and fewer drugs. The healthcare providers offer lower prices in this environment because they see the government saying no buy in many cases. For example, single-payer countries buy less cancer treatment. For a given sized and staged cancer tumor, they buy less. The gap between the amount of cancer treatment we do and the treatment they do at a given sized tumor has been increasing over time. The data I'm showing here are for Europe, which includes some countries that are not single-payer, but we see that Americans survive cancer longer and that the survival gap grew during the 1980s and 1990s. The United States also spends more on cancer screening, but that is not shown in this picture because the tumor is held constant. This next slide shows the types of cancer. The United States is way ahead in prostate and breast cancer. However, we are a little behind on uterine cancer. We already saw that we appear to be getting something more for the extra we spend on cancer treatment. But is it enough to justify the extra cost? It appears to be, as this chart suggests. With COVID-19 out there is a lot of talk about the availability of hospital beds, especially beds in intensive care. The United States is way ahead of most countries in terms of the per capita number of beds we have. So this is something we have been getting extra for the extra we spend on health care. This year we especially appreciate it. Remember that many countries outside the US are not single-payer countries. So it would be interesting to single out the single-payer countries and see where they stand. Sure enough, single-payer countries are at the very bottom. One way they are saving money is by having fewer critical care beds around. Last week we talked about price regulation. Is single-payer a price regulation? It would be if it said that co-pays had to be zero. So let's put that aside. We're thinking about single-payer with co-pays. The single-payer negotiates lower prices. Is that a price regulation? In theory, single-payer is different. Price regulation does not shift the demand curve in. We even saw last week how it can shift the demand curve out. The single-payer shifts in the demand curve. It will prohibit certain types of care that it says is unnecessary. It refuses to buy certain drugs. No joint surgery after you hit a certain age. That's the whole way that it might achieve lower prices. In theory, patients in single-payer countries would not necessarily be waiting in line. The single payer is preventing some of the patients from even getting in the line in the first place. But it does not always work this way in practice. It is tough for a regulator to say, no knee surgery for you. Life is better if the regulator avoids saying no and lets a line form instead. As the regulator, he can even let his friends cut in the line. Well-connected people will jump ahead in the line. A bit like Chicago's mayor got a haircut before I did. I think it is too extreme to say that single-payer must have lines. It will do at least a bit to keep people from joining the line. But still it is worth checking. Do single-payer countries have longer lines in reality? In the 2019 Economic Report of the President, we looked at a couple of measures of lines in healthcare. Here is one measure, the percentage of senior citizens who had to wait at least 4 weeks to see a specialist. A majority of seniors in the United Kingdom, Norway, Australia, and Canada were in that situation. 3 of those are single-payer countries. The countries with fewer seniors in line are not single-payer. Adjusted for population, the US has the fewest seniors in line. I was hard on the waiting tax model last week. I said the quality model is better. But maybe the waiting tax model works in some important situations like the one we see here.